Hello, good afternoon, everybody. Thank you to attend today's webinar. My name is Ian Liu, Chief Medical Officer of Median Technologies, and I will be the moderator of today's session. Today, Median will bring you an interesting topic regarding the response criteria on primary brain tumors. And here, we will also introduce you the methods on implementing central reviews with RANO criteria. We have two experts on our panel today, Dr. Antoine Yannissi. Antoine is the Medical Director of Median Technologies, radiologist specializing in oncology with more than 10 years clinical academic research and also industry experience. He is the former head of Interventional Oncology Department of Cancer Center, Nice Unicancer, and his main research interest is validation of imaging biomarker in cancer research. We also have Dr. Jennifer Chilero. Jennifer is our clinical scientist. Jennifer holds a master's degree in clinical research, biostatistics, human pathology, and also a PhD in human pathology and neurology. So before being clinical scientist, Jennifer served as project manager at Median. So she is also very familiar with all the operational challenges with different criteria. So before we start the webinar, we have two questions, and it is great to have your feedback. So, have you used or do you plan to use RANO criteria to evaluate a central nervous system disease? No? Yes? For primary brain tumors? Yes? For metastatic disease? Yes? For pediatric patients? So now let's vote. Okay, let's see the results. Okay, great. We have a 75% that's use RANO for primary brain tumors, great. And also 25% have used it for metastatic disease. Great, interesting feedback. Okay. Let's see the second question. So what is the discrepancy rate between the site assessment and the central review assessment when using RANO high-grade glioma? So what's your expectation or your thinking? Less than 25%? Between 25 to 50%? Between 50% to 75%? Or more than 75%? So let's vote. Okay, good. Let's see the results. Okay, it's interesting. Okay, see that 70% expect it's less than 25%. Right? And most of our colleagues voted for between 25 to 50%. And also, we also see 17% choose between 50 to 75%. Okay, it's good to know. And we will see, so today's presentation, you will see how we can reduce the quantity discrepancy. And also, this will be an interesting topic for today's webinar. Great. So, and also, a kind reminder that you could raise your questions through the question pane during the webinar, and we will also answer all your questions at the end of the webinar. So now, Antoine, the floor is yours, please.
Thank you, Dr. Liu, for this introduction. Indeed, the response was really interesting, with no surprise, the discrepancy rate is indeed more close to 50% than 25%. So the aim of today is really to give you some presentation in order for you to understand what are the drivers of this discrepancy, how you can reduce this discrepancy, and what's the use of the central review. We will go through the standardization of the image acquisition, what are the drivers of this image acquisition standardization for the central review, and my colleague Jennifer will go through the clinical information, which is really specific for RANO assessment and actually highly needed for this evaluation. So, starting with the radiologic assessment in neuro-oncology, the idea is to present here the RANO criteria, the work group also, and to discuss about the limitation of this criteria. The radiographic assessment in neuro-oncology, the standard of care is known for many years now. It's based on the local treatment and the systemic treatment. If we take the example of the glioblastoma, we have surgery, we have radiation, and based on these treatment, the overall survival is not really high. Because, for example, for high-grade glioblastoma, we have 10 to 15 months of survival. So in this context, the imaging biomarker that we try to use will provide some surrogate endpoints, which are the progression-free survival and the overall response rate. These surrogate endpoints are actually here to try to shorten the trials, and in this context of very poor survival, they also are very useful for crossover study design. The biomarker itself is based on the MRI with two types of biomarker. The first one based on the T1 weighted images, and it's basically the enhancement of the lesion. The T2 biomarker based on the T2 weighted images, and which is more based on the infiltration of the lesion and the surrounding tissue that you can see respect to the T1. So these two biomarkers are known and used for the evaluation of the disease. Problem is that we know that there is some interference between both local treatment and systemic treatment with this imaging profile and biomarkers. Especially since the introduction of novel drugs, there is what we know as the paradoxical response. I will go through this type of scenario, which are confusing for the criteria on the next slides. So the problem when we have these issues is that the correlation between our surrogate imaging surrogate endpoint and the overall survival is not robust. So we will discuss if it's still the case to think that the imaging endpoint can be taken as an endpoint for the trial, or should you take or rely on the overall survival. In addition to that, and that's why we introduced the last topic on the clinical information, knowing that there are some limitations. One way to overcome such limitation is to introduce an additional marker, which is based on the clinical information and clinical evaluation. That's why it's really important for the radiographic assessment in neuro-oncology. So if we go through the imaging biomarker, there's a group since 2010 working on the response assessment in neuro-oncology, the RANO group, which is interdisciplinary, which was based initially, and we take the work of the McDonald criteria, which is, as you see, based on imaging, but not only imaging, also the clinical information and the corticosteroid status, which is the one of the standard of care when for neuro-oncology disease. So the group aim was to improve and standardize the assessment. That's why we will go through the guideline that they published. It's good to know that different type of central nervous system are addressed in their guidance. It's also good to keep in mind that these guidance are evolving in time. Just for to give an overview, as you can see, there is many workforce within this group working on glioblastoma, but not only. There are some specific work group working in for brain metastases, for pediatrics indeed. And regarding the glioblastoma, these criteria evolve at the same time than technology evolved. In 1990, the evaluation was done by CT, and nowadays it's done using MRI. So you can see that the first version of McDonald criteria was based on the CT modality, while the latest is based on the MRI modality. And also with the improvement of imaging, they include some volumetric assessment, which need some really small thickness of images. And that's possible now, while in 2010, it was not the norm. So keep in mind that this criteria evolve, and it's really important to use the latest criteria when you assess your, when you want to use the RANO criteria. So one common question is, knowing the context, and there is this so short overall survival, especially for glioblastoma again, should we use actually some surrogate, and is there an interest to use the imaging endpoint as a surrogate endpoints? So when you look at the studies that are published and are in line to be for validation for the drugs, actually the progression first free survival set as 6 months. It's widely used for phase 2 and phase 3 validation. The independent central review for such criteria is really needed because you will avoid some bias. I will detail the difficulties of the assessment just for the investigator side. And so we can actually take the progression-free survival as one reliable imaging endpoint for the study endpoint. For the overall response rate, it's more difficult indeed, because the subjectivity of the disease evaluation is really important. So it's more it's less reliable than the progression-free survival, and you will probably understand when you will see what are the scenarios that actually put this endpoint in difficulty. In addition to that, often for early phase study, there is some additional biomarkers that are used, and I would say that in this context they are very useful. They will give you some more information, and they will help to overcome some limitation of the RANO criteria, considering this this scenario that we just say about pseudo progression, pseudo responses. So it's important to collect some more information. But the difficulties here, if you look for independent central review, it's really the standardization, because those biomarkers are really difficult to standardize. So the central review will help you to get some reliable biomarkers between your different sites. So what are the confounding factors when you assess neuro-oncology? So let's take this patient which has a glioblastoma. This is the baseline, and we go over time in this until these 10 weeks here. As you can see, initially the lesion and the T1 tend to increase. So the patient here could be set as a progressive patient. But if you look well, the next assessment shows a really important decrease of this lesion. So this type of scenario is known as pseudo-progression. It's basically a paradoxical increase in the contrast enhancing tumor or a new enhancement, but the patient remains clinically stable. So it does not mean for this patient that the drug is not efficient. It's actually based on the brain-blood barrier, which has been modified and let the enhancement pass through. So that gives a pseudo type of pseudo progression images like this. So the RANO guideline, the latest RANO guideline, make the difference between the true progression and what they call a pseudo progression. How do they do that? They set a threshold in time where the progression can be actually activated. So 12 weeks is the minimum time between the baseline and the declaration of one progression. there can be also a true progression confirmed through pathologic confirmation. So of course, this is way less frequent. And the last information that can help to define a true progression versus pseudo progression is the radiation field, and that join the difficulties to collect such information. My colleague Jennifer will explain how those information are really precious and they should be collected centrally. So our advice to cover such scenario is to consider, especially for early phase, to have an exploratory endpoint, which can be based in diffusion. Diffusion because, as we will see, the diffusion images are often by default on such evaluation. So there is also another type of scenario that can confound the actual response of the patient. So let's take this second example. If this patient is treated with cediranib, and this is the baseline, at 3 months and a half, seems that the patient actually is really responding to the drug on this biomarker, which is the T1 enhanced biomarker. But if you look at these images, you will notice that while here there is a decrease of the lesion, here it seems that the lesion has increased. So this type of scenario is known as pseudo response. So it's a rapid decrease in the contrast enhancing tumor, and it's actually without a true anti-tumor effect, because over time, if we follow this patient, you will see that on the second biomarker that is basically the T2 or the flare images, the patient will actually be worsening. So again, here, the latest RANO guideline make the difference between the durable partial responses and the pseudo partial responses. So these responses to be considered as true and so durable should be confirmed after 4 weeks. So that's the way they overcome this type of scenarios. Our advice here is to really use, as actually mentioned in the RANO criteria, the latest RANO guidance, the subtraction map. So I will detail that. Why? It's basically because it will increase the sensitivity of this biomarker, the T1 biomarker. So what are the drivers of this variability, and how can we help that centralizing the image and having a central reading? So the main driver of the variability between the readers is the T2 and flare biomarker, because this non-enhancing part of the tumor is assessed, but is assessed subjectively. So when you assess something subjectively, you, by definition, you will have more variability. So to decrease your discrepancy between the reader, it's really important to assess your case using a neuro-oncologist and neurologist, which are very experienced. You also have to include some challenging cases to train those readers in order to standardize their interpretation. Really important also to use these challenging cases over time when you are going through your study. And another way to cover the scenarios that I just described is to use a global review at the end of your assessment per patient. So that will give indeed a global overview of the patient profile and allow the reader to correct their assessment. Another way is to have a design having 2 readers plus 1 adjudicator, and in this case, the adjudicator will have the overview and can help to better assess the profile of the response. The second drivers of variability are the tiny lesion and also the cystic or necrotic glioblastoma, which are actually frequent. So when you see that a lesion is like this, you understand that if you ask one reader to measure it, it will be highly variable. So to overcome this limitation, the latest RANO M-RANO criteria introduce the volumetric assessment, because indeed you will decrease variability when you have the volumetric assessment. Of course, one of the variability drivers is the atypical responses that we described. So the RANO try to adapt, and when you use the immunotherapy on such disease, you can use a specific criteria that will try to cover this scenario in case of occurrence. I will go through different type of specific responses that are covered. Another way is to customize your imaging reading criteria, taking in account that you can have some atypical responses. And also, as we said, to have some additional biomarker to try to understand if your patient is actually going through a true progression or pseudo progression. So these are some examples of additional type of response that are added within the RANO criteria. So the first RANO criteria introduced the pseudo progression. The M-RANO introduced the pseudo responses. The I-RANO introduced a specific type of pseudo progression, which is immune pseudo progression. And also you have, for some specific disease, an additional type of responses. So some important message here is that the immune pseudo progression is not covering all type of immune pseudo progression indeed, because it's working a little bit differently for those who know the iRECIST. It's working basically using a time frame. So I described previously the time frame, which is based on 12 weeks. For immune pseudo progression, it's based on 6 months. So you can't have progression when using immunotherapy before 6 months, but actually the true progression is defined after 6 months. But the problem is that you can't have a multiple pseudo progression on the same patient. And this is a limitation, especially for certain type of immune therapy that we know now that the pseudo progression can occur more than 6 months, even way more than that, because you can have like pseudo progression more than 1 year after the baseline. So that's not actually the I-RANO is still there is still room for improvements there. Latest driver of inter-reader variability, as we saw initially, there are some lesions which are faintly enhanced. There is a 2D measurement variability between the reader, which is intrinsic and not specific to RANO. And there is also difficulties due to the modality for standardization. So to cover this limitation, we will go now through the image acquisition guideline, and we will describe the interest of subtraction and volumetric assessment. So the image acquisition guideline that are used and recommended by RANO are based on a publication in 2014 and more known to the Brain Tumor Drug Development Coalition. So this paper will describe basically all the guidelines and the way we can standardize acquisition. Just before that, I want to point out that there is different need for standardization. There is, of course, the need of standardization between different type of sites, because there is different type of machine, different type of protocol. But if you look at one patient, for the same patient, even though this patient would go to the same hospital, the protocol might change in the same hospital and might be not consistent. So there is a way, there is really two type of consideration regarding the standardization of the acquisition. Not only the protocol, and the protocol don't solve all this problematic. So the role here of an imaging CRO is actually to make sure that this protocol will be implemented on site and check if there is any deviance from this protocol. As you know, probably your site is not really always keen to change their routine protocol. But for the brain tumor imaging protocol in clinical trials, there is a way that you can actually add some additional sequences in order to cover and to keep the routine assessment together with the clinical trial assessment. So there is always a way to speak with your site, not to change all the habits here. So what are the key points for this protocol? The first one is the 3D assessment. So as you can see in this image, if the patient is positioned differently, this is the same patient positioned differently on the machine, the assessment is really different from for the same reader. So this three-dimensional assessment will overcome this limitation. The second most important implementation on the latest RANO criteria and the protocol is the use of subtraction. So the subtraction is made between the post-contrast assessment and the pre-contrast assessment. And you will get an additional parametric images. And as you can see here, it reveals the tumor way more than just using the T1 after contrast. So about the three-dimensional assessment, we have many questions from sponsors. Should I use it or not? So basically, there is pros, there is cons, because at the moment, if you want to use three-dimensional assessment, you still have to use manual or semi-automated 3D segmentation, okay? And those actually are not standardized. So this is the only cons, because of course it will overcome all the limitation and the variability that we assess. So our approach is actually indeed to use the volumetric assessment and to still derive the 2D assessment based on this contouring. Last test point, which seems really important in the protocol, is to try to assess the longitudinal assessment consistency. So this is easily done by checking the DICOM tags. The DICOM tags are tags that you have in the image to see if the patient has changed the type of MRI, the timing of injection, try to get the type of agent and dose that has been injected. This has shown to be impactful for the variability. And the last key point is the use of the diffusion. Diffusion is part of the protocol as by default. The central assessment is limited, but it's feasible. And the challenging here is the standardization. So this said, I will now give the hand to Jennifer.
Thank you, Antoine. So now we will address the critical question of clinical information collection for central read in RANO context. Okay, so RANO is a complex criteria which require integration of clinical information at several levels. So basically, we are collecting imaging acquisition from the site. So here, brain MRI most of the time. And we are also collecting radiotherapy information, prior radiotherapy information, but also concomitant radiotherapy information, which is quite standard as for RESIST, but for RANO, it's particularly crucial, and I will explain later why. So we are also collecting biopsy information if applicable, and all the information are submitted to the readers, to the radiologist, to have the radiological response according to RANO. But there is a second level for the clinical information. The radiological response for RANO is also combined with the corticosteroid status and with the clinical patient status to assess the overall RANO assessment. So basically, why prior and concomitant radiotherapy information collection is so important for RANO. As you may know, for RESIST, the hereditary lesion should not be chosen as target lesion unless they have progressed since the radiotherapy. But for RANO, it's really different because of the indication and because of the treatment for glioblastoma. The hereditary lesion can be chosen as target lesion, but this hereditary lesion cannot trigger the progression for 12 weeks after the radiation because of the phenomenon of pseudo-progression explained by Antoine just before. As explained before, the irradiation is causing some increase in the contrast, and it's not linked to the actual progression. So during the 12 weeks after the completion of the radiation, progression can be only triggered outside of the isodose line, the 80% isodose line, or if an histopathologic sampling show an unequivocal evidence of progression. That is why it's so important for Median to collect the specific location of the radiation, the dose, but also the date to compute the 12 weeks window information. All this information can be also collected through the RT plan or report information, which is including also the isodose line. So the second level of clinical information that should be collected is for the overall RANO response computation. So as you can see in this table, the radiological time point response according to RANO is computed based on the image, but to have the overall RANO assessment, you should also integrate the clinical information, which includes the corticosteroid and the clinical status. But this overall RANO assessment is based on the variation of the corticosteroid and the variation of the clinical status, which is basically scaled through KPS or WU scaling. So median is not supposed to collect the gross value, but directly the variation, which are directly collected through the ECRF. So it's highly recommended for median and for the imaging CRO to not compute outside of the ECRF variation, but to collect directly the variation of the clinical status or the variation of the corticosteroid through the ECRF to avoid any additional computation of the ECRF or some discrepancies between the site and the central assessment. So here you have a global RANO assessment workflow. So first, as mentioned before, radiotherapy information, which include the prior radiotherapy and the concomitant radiotherapy information, together with the lesion biopsy information, are collected through the ECRF, and then they are integrated directly in LMS by the image manager. All these information are submitted together with the imaging acquisition to the independent radiologist. The independent radiologists are performing the RANO radiologic time point response. And in the other end, you have the clinical status variation and the corticosteroid variation that are also collected through the ECRF, not the gross value, but directly the variation. And this information, this clinical information, are also integrated directly in LMS system. Then LMS is combining the radiologic response, the radiologic time point response, which has been assessed by the radiologist, together with the clinical information that have been directly extracted from the ECRF to compute using an automatic algorithm, the overall RANO response. This overall time point response can be also optionally validated by a neuro-oncologist depending on the sponsor requirement. So what you should keep in mind, the clinical information for RANO is really crucial and challenging, and this collection is really important. It's really important for you, sponsor, to involve Median at the very early stage of your study to ensure that your study ECRF is collecting all the required information for RANO. This should include at least the prior and the concomitant radiotherapy information with a precise location, the dose, the date, which are required for the pseudo progression assessment, but also the potential lesion biopsy information, the variation of a corticosteroid and clinical status in order to be able to compute the overall RANO assessment. And the question of the time window for this clinical data should be also addressed really early in the ECRF design. Last point, LMS system is providing an integrated and automatic solution which is able to compute the overall RANO time point response based in one hand in the radiologic on the radiologic RANO assessment, and in the other hand on the clinical information, which include the corticosteroid and the clinical patient variation status. Thank you.
Oh, great. Thanks, Antoine and Jennifer, for the excellent presentation. And also that also highlighted all the challenges and how to manage the risks for central nervous system disease. The next slide, please. So now we will conclude. So as Antoine just gave us the concrete example, radiological assessment could be sometimes challenging, unlimited, considering pseudo progression or pseudo response. Therefore, it is key to understand the mechanism of action of the drug and how to use appropriately imaging methods. We also know that overall survival remains the gold standard endpoint for regulatory bodies. However, overall survival exhibits also disadvantages in its inability to account for post-trial life prolongation therapy, and which is far from standardized. So overall survival also takes significantly longer in trial due to extended follow-up. Therefore, reduction in time required is also meaning use that progression-free survival could be utilized as an alternative endpoint. As Antoine mentioned, that PFS 6 months is a reliable surrogate endpoint for phase 2-3 studies, as it's also allowed imaging to take place over an adequate amount of time, which is longer time point is better associated with overall survival as well. Also, as mentioned, that objective response rate can be used for secondary endpoint for efficacy, which may also require for central reading. And also, in addition, exploratory endpoint supported by additional images such as diffusion, perfusion, metabolic images, or MR spectroscopy can also be used for disease differentiation or response assessment. The high quality imaging is the key to success. And also, as mentioned, based on the 2015 guideline, there was a clear instructions for image acquisition. So therefore, complying with the image acquisition guideline can help to reduce the discrepancy. The last but not least is also the importance of centralizing the clinical information. So this information should be centralized in the ECF, as Jennifer mentioned, and also planned at the initial study design. So thanks for your attention. And now I would suggest that we can go to the Q&A session. So Antoine, Jennifer, yeah, the floor is yours again.
So let's see if we have questions. So I have one here. So from your point of view, where are the rooms of improvement for RANO criteria? So as indeed we described, the rooms of improvement are really in the RANO criteria, abilities to actually cover new drugs and especially immune therapy, vaccine therapy, because at the moment, the RANO that has been published still is not so robust as the irises, for example, that can cover many subsequent pseudo progression. In here, we have only one scenario like this, so it's for sure more limiting. There is also some improvement in the additional biomarker that we mentioned, diffusion, perfusion. Maybe there's a way here to try to solution some difficult scenario in the assessment. These are my guess for the next publication, probably. Yeah. I think, Jennifer, maybe you have one question. What is an endpoint?
Yes, what is an endpoint? So an endpoint is an event or an outcome that can be measured objectively to determine if there is a benefit or not with the treatment. We have also a question. Is there a time window for clinical information collection? So it's a good question also. It's something that we have mentioned at the end. It's really important also to collect the patient status and also the corticosteroid level the same day as the imaging acquisition. The problem is not when the collection is done. It can be done after for the ECRF, but it's really important to have the clinical status assessment done the day of the acquisition, the same for the corticosteroid.
So there is one question for me, I guess, which is, can you explain again the key differences between the initial RANO and the modified RANO? So, and indeed, so there is differences. The RANO criteria initially described the scenario of the progression, the one that actually can happen before 12 weeks. So they describe this and the notion of the true response versus the pseudo progression. But the latest version of RANO, the mRANO, introduced the preliminary responses, which cover the pseudo response by the durable response. That actually makes the difference between what would be a pseudo response with respect to a true response. So that's one big difference, one huge difference. They also introduced the mRANO, introduced the volumetric assessment. So you can have mRANO in 2D or mRANO in 3D. That's a huge difference because the thresholds are different in 2D and 3D. So you cannot just like mix 2D and 3D easily. That's for us something. This is really something to challenging. And also the subtraction. So the subtraction was introduced indeed initially, but also through the as we said, the acquisition guideline. It was immediately, and it was also something that was used actually routinely. But indeed, it's really recommended to use the subtraction to assess on the T1 enhanced biomarker, because the subtraction will help you to define better and measure better the lesion. So that these are the main differences and the main evolution of the RANO criteria. Yeah.
Indeed, indeed. That's very helpful. Thanks, Antoine, and also Jennifer. I know that now, time go very quick, and we have to enter in also the conclusion at the end of the session. Thanks all to attend this webinar and all your questions. And you can also find the replay at Median's website or through the LinkedIn. And if you need a copy of this presentation, you can also send an email of the request to info@mediantechnologies.com. And also hope that we can also see each other again for our next webinar. And I will wish you an excellent evening. Thank you. Bye.
Thank you.
Thank you.